We go on this incredible journey every single day, and most of the time we don't even think about it. It happens every time we eat. So today, we're going to follow our food on its wild, winding path through the body and really uncover the secrets of our own digestive system.
I mean, it seems like such a simple question, right? You take a bite, you chew, you swallow, and then what? Where does it even go? Well, it vanishes into this complex, hidden world inside your own body. And today, we are pulling back that curtain.
Okay, so here's our map for the trip. The gastrointestinal tract, or the GI tract, is basically just one long winding tube from start to finish. We're going to make stops at each of these key locations to see exactly what's happening along the way.
And our journey kicks off with Phase 1, the Great Breakdown. This is where food first enters the system and starts its amazing transformation.
The second food enters your mouth, digestion is already underway. Seriously, your teeth get to work on the mechanical part, grinding everything into smaller pieces. But at the exact same time, your saliva starts the chemical digestion, using enzymes to break down carbs before you've even swallowed.
So once you swallow, you might think food just kind of drops into your stomach. But that's not what happens at all. It's actively pushed down your esophagus by this powerful process called peristalsis. It's this incredible automatic muscle wave that makes sure your food gets where it's going, even if you were eating upside down.
The whole process is actually pretty simple, but it's so powerful. The easiest way to picture it is like squeezing a tube of toothpaste. Muscles contract in a coordinated wave right behind the food, creating pressure that just pushes it forward, rhythmically, all the way down to the stomach.
Welcome to the stomach. Think of it like a muscular mixing chamber. In here, the food gets churned and mixed with some seriously powerful gastric acids and enzymes. And this digestive cocktail is especially good at one thing, breaking down proteins from stuff like meat, beans, or cheese.
So after a few hours of all that churning in the stomach, our food is completely transformed. It's not even recognizable anymore as what you ate. It's now this semi-liquid paste called chyme. And this chyme is officially ready to move on to the next and, I'd say, most important phase of its journey.
So now we're entering Phase 2, the nutrient extraction zone. Honestly, if digestion were a concert, this is the headliner. It's where your body finally gets to pull out all the good stuff, all the valuable vitamins, minerals, and energy from the food you ate.
And the absolute star of this show is the small intestine. This long, coiled-up tube is the main place for nutrient absorption. As food passes through its different parts, specific nutrients like iron, vitamins, and fats are systematically pulled out and sent off to wherever the body needs them.
So, what's the secret to the small intestine's incredible power? Well, its inner lining isn't smooth at all. It's covered in millions of these tiny, finger-like things called villi. This design is just a masterpiece of efficiency. All these little folds and fingers increase the surface area so much that it's roughly the size of a tennis court. All that space is for nutrients to pass into your bloodstream.
Now, the small intestine doesn't work alone. It has this essential support crew, the liver, gallbladder, and pancreas. The liver makes bile to break down fats. The gallbladder stores that bile until it's needed, and the pancreas sends over this cocktail of powerful enzymes to digest fats, proteins, and carbs. They're basically the pit crew of digestion.
And that brings us to our final stage, Phase 3, water, waste, and microbes. This is what happens to everything that couldn't be absorbed. So anything left over moves into the large intestine, which you might know as the colon. Its main job is to soak up most of the remaining water and electrolytes, which is absolutely crucial for keeping your body hydrated. This process is what solidifies the waste, getting it ready for, elimination.
Trillions. Just let that number sink in for a moment. Trillions. What could we possibly have trillions of inside our own gut? It's not our own cells. It's not leftover food. It's an entire living ecosystem.
The answer is the gut microbiome. Your GI tract is home to this massive community of trillions of helpful bacteria. They are vital partners in digestion. They help break down things we can't digest on our own, and they play a huge role in our overall intestinal health.
So, we've reached the end of our food's journey. But what's the big takeaway here? Why does understanding this whole complicated process actually matter for your daily life?
Well, when you zoom out, you can see the entire GI system as this elegant, super efficient factory with 4 main jobs. It takes in raw materials, ingestion. It processes them, digestion.
It extracts all the valuable parts, absorption. And finally, it manages the waste, excretion. Every single step is perfectly coordinated.
But ultimately, the journey we just witnessed is about so much more than just processing a meal. A healthy, well-functioning digestive system is really the foundation for your energy levels, the strength of your immune system, and truly your entire sense of well-being.
Which brings us to this final, really important thought. That community of trillions of microbes in your gut, it's completely unique to you. It's like a fingerprint, and it influences everything from your mood to your immunity. So the question to leave you with is this: are you taking care of yours? Thanks for tuning in.
You know, whatever you last ate, right now, it's on this incredible, totally automated journey inside your body. It's a system that's running 24/7, perfectly coordinated, all without you having to even think about it. So let's follow that journey and see just how it all works. So, have you ever really thought about it? You take a bite, you chew, you swallow, and then what? It's so easy to just forget about it. But that bite of food is just beginning a really complex and powerful trip. And in this explainer, we're going to follow that path step by step.
Well, this whole journey is possible because of something called gastrointestinal motility. Now, that sounds pretty technical, right? But all it really means is the coordinated muscle movements that push food all the way through your digestive tract, making sure everything gets digested, absorbed, and, eventually eliminated.
Okay, so to make this all happen, your gut relies on two main moves. You can think of them as the push and the churn. They're both absolutely critical, but they have totally different jobs. So let's break them down. All right, first up is peristalsis. This is the big push. I want you to imagine a powerful, rhythmic wave moving down a tube. That is exactly what's happening here. It's like your body's own internal conveyor belt, just methodically moving everything forward, all the way from your esophagus to the finish line.
And then you've got its partner, segmentation. So if peristalsis is the conveyor belt pushing things along, think of segmentation as a cement mixer. Its whole job isn't to move things forward, but to churn and mix everything up. These rhythmic squeezes make sure every little bit of food gets covered in digestive enzymes so you can absorb all the nutrients. So you've got two completely different but equally vital actions going on. Peristalsis is all about that forward-moving push. Segmentation is all about that rhythmic squeeze to mix things up. You absolutely need both the conveyor belt and the mixer to get the job done right.
Okay, so who's the director of this whole show? Who's telling the muscles when to push and when to churn? You'd probably guess it's your brain, right? Well, not exactly. The gut has its own on-site manager, a system so smart it's earned a really impressive nickname. It's called the enteric nervous system, but a lot of scientists just call it our second brain, and for very good reason. We're talking about a network with over 100 million neurons. That is more than your entire spinal cord. It pretty much runs the whole digestive operation on its own, without constantly having to check in with headquarters up in your skull. And just look at its to-do list. It's managing the timing of that peristalsis push, it's controlling the release of enzymes, it's even directing blood flow to help absorb nutrients. It's a full-on command center down there, and it's working almost entirely by itself. Now, this second brain is brilliant, but it isn't working in a vacuum. It has this whole team of chemical messengers, hormones, that are zipping around sending signals to keep everything perfectly coordinated. Let's meet a few of the key players.
Let's start with gastrin. Think of this as the get-ready signal. As soon as food hits your stomach, gastrin basically shouts, "All right, team, we need more acid. Let's go." And that acid is crucial for breaking down protein and killing any bad bacteria.
But, you can't just have that super strong acid flowing everywhere. So as the food moves on, another hormone called secretin jumps in. It's the, okay, calm down, neutralize that acid messenger. It's an incredible chemical balancing act. So what about fats? Well, when your gut senses fat has arrived, it sends out a hormone called CCK. That's a direct signal to your gallbladder saying, hey, we need some bile over here, stat. And that bile is what's needed to break down and absorb those fats. With all this go, 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 the system also needs a brake pedal, right? Well, that's somatostatin. It's the, whoa, slow down hormone. It sends a message to everyone to just take a breather, tapping the brakes on digestive activity to make sure everything happens at the right pace. And then, of course, there's the one you probably heard of, ghrelin. This is the famous I'm hungry hormone. When your stomach is getting empty,
Ghrelin is the messenger that runs up to your brain and yells, "Hey, it is time to eat."
And you can really see the beautiful balance right here. You've got hormones like gastrin that hit the accelerator, and then you have others like secretin that pump the brakes. It's this constant chemical conversation, this perfect push and pull that makes the whole system run smoothly and safely.
So this whole system is amazing when it's working right. But what happens when the timing gets off? When things start moving a little too fast or way too slow? Well, the results are probably something we're all familiar with.
You can think of it like a speedometer for your gut. If things are moving too slowly, food just hangs around too long, and you get constipation. If things are flying through too fast, your body doesn't have time to absorb water properly, and that leads to diarrhea. The goal is always to stay in that sweet spot right in the middle.
And really, problems with this internal speedometer are at the heart of so many common motility disorders. We've talked about constipation and diarrhea, but it can also cause things like gastroparesis, where the stomach literally empties too slowly, or the really complex timing problems you see in irritable bowel syndrome.
So when you boil it all down, here's the big takeaway. The seamless journey your food takes isn't an accident. It's an incredibly complex, perfectly timed dance. It absolutely requires the physical force from your muscles, the intelligent direction from your second brain, and the precise chemical signals from your hormones, all working together in perfect harmony. It's just wild to think about, isn't it? All of this complexity is happening inside you at this very moment. Your body is constantly sending you signals: hunger, fullness, comfort, discomfort. Your gut is definitely talking. The only question is, are you listening?
All right, let's dive right in. Today, we're taking a little tour of the upper gastrointestinal tract, and we're going to break down 3 very common but often misunderstood disorders. We're going to get to the bottom of what they are, what they actually do to your body, and how they're managed.
I mean, who hasn't felt this, right? That classic burning feeling after a big meal, or maybe just a dull ache in your stomach that won't go away. These feelings are super common, and they're exactly why it's so important to understand what might be going on in there. They're basically signals from your body telling you to pay attention.
So what part of the body are we even talking about? Well, the upper GI tract is pretty much the front door to your whole digestive system. We're talking about the esophagus and the stomach. This is where all the initial, heavy-duty work of breaking down your food happens, and if something goes wrong at this gateway, you can bet the whole system feels it.
And the warning signs, they're usually pretty hard to ignore. We've got that classic heartburn, of course, but also things like having a tough time swallowing, actual abdominal pain, and that general feeling of nausea. These aren't just little annoyances. Think of them as clues that can point us toward what's really going on.
Okay, now before we get into the nitty-gritty, we have to talk about a critical safety warning. This is huge. If a patient has trouble swallowing, the medical term is dysphagia, or if they're in C-spine precautions or have a high risk of food going down the wrong pipe, you just can't give them oral medications. No pills. It's a huge no-go, and it can be really dangerous. That's why you see healthcare pros use other routes, like an IV, to keep patients safe.
All right, so here's our game plan for today. We're going to treat this like we're solving a few case files. First up is the sneaky stomach invader, H. pylori. Then we'll look at a kind of swallowing traffic jam called achalasia. After that, we'll tackle the infamous GERD, and then we'll wrap it all up with a solid management playbook. Okay, let's open our first case file. Helicobacter pylori. The best way to think about this one is as a tiny but incredibly tough invader that decides to set up shop right where it doesn't belong, inside your stomach.
So what is it officially? H. pylori is a type of bacteria that infects the lining of the stomach. And it's not just hanging out in there harmlessly, oh no! It is a leading cause of peptic ulcer disease, which, as you can imagine, is behind a lot of stomach pain and serious issues.
So how does this little bug pull it off? Well, it has a pretty clever invasion plan. First, to survive in that super acidic stomach, it actually neutralizes the acid right around it. It creates a safe zone. Then, once it's comfortable, it starts to damage the stomach's protective mucus layer. With that shield gone, the acid can now get to the sensitive tissue underneath, and that leads directly to inflammation and those painful ulcers. Pretty sneaky, right?
Now, the clues this invader leaves behind are pretty distinct. The big one is a burning pain in the abdomen. And here's the key giveaway. The pain often gets worse when your stomach is empty. Why? Well, there's no food in there to act as a buffer, so the acid is just directly irritating that ulcer.
You might also feel nauseous, lose your appetite, and in more severe cases see dark, tarry stools, which is a sign of bleeding.
So how do you fight back against this thing? With a smart two-pronged attack. Step 1 is to reduce the amount of stomach acid using something called a proton pump inhibitor, or a PPI. This gives the ulcer a chance to actually heal. But at the same time, you launch step 2. You hit the bacteria itself with 2 different kinds of antibiotics. This combo is absolutely crucial to make sure you wipe out the infection completely and stop it from coming back.
Okay, on to our second case file. This time we're not dealing with an invader. This is more of a mechanical problem. We're talking about achalasia, and you can think of it as a total gridlock, a traffic jam right at the bottom of your esophagus.
So the issue here is with a little muscular ring called the lower esophageal sphincter, or LES for short. It's basically the gatekeeper between your esophagus and your stomach. With achalasia, this gate just won't open. It fails to relax when you swallow, which means food can't get through into your stomach.
And here's what that looks like in action. Normally, you swallow. The gate swings open, food passes into the stomach. Simple. But with achalasia, it's gridlock. You swallow, but the gate stays shut, so the food has nowhere to go and just gets trapped, backing up in your esophagus.
And the symptoms are a direct result of that traffic jam. The number one clue is difficulty swallowing, but people also experience regurgitation of food that never even made it to the stomach. It can also cause chest pain, and over time, because you're not getting enough nutrition, it can lead to some pretty significant weight loss.
And this is such a key diagnostic clue. When a patient tells you, it literally feels like food is stuck in my chest, achalasia should be at the top of your mind. It's a very unique and telling sensation that points right to this mechanical problem.
So how do you clear the gridlock? Well, you have to physically get that gate open. One way is to use a balloon during a procedure to stretch and widen the sphincter. Another option is surgery, to actually cut some of the muscle fibers, which helps it relax permanently. It's all about physically fixing the blockage.
All right, our final case file, and this one is by far the most common one you'll hear about. It's GERD, or gastroesophageal reflux disease. Now with this one, the problem isn't a gate that's stuck shut. It's a gate that's too loose, allowing stomach acid to fight its way back up.
At its heart, GERD is really a plumbing issue. You've got all this powerful stomach acid that's supposed to stay put, but instead it flows backward. It refluxes up into the esophagus. Now, the esophagus lining just isn't built to handle that kind of acid, so it gets irritated and inflamed. And that's a big deal, because over time, that constant irritation can lead to more serious problems. So again, let's think about that gate, the LES. In a healthy person, it's a strong, tight, one-way door that keeps the acid where it belongs. But in someone with GERD, that door is, well, it's loose. It doesn't seal properly, and that allows acid to splash back up into the esophagus.
The number one symptom, the one everyone knows, is heartburn, that burning feeling in your chest. And it's often way worse after a meal or when you lie down because, gravity isn't helping you out anymore. People also report acid regurgitation, general chest discomfort, and sometimes even difficulty swallowing.
Managing GERD usually takes a two-part approach. On one hand, you have lifestyle changes, simple stuff really, like eating smaller meals, staying away from trigger foods like spicy or fatty things, and maybe propping your head up with an extra pillow at night. Then, on the other hand, you have medications, things like PPIs and H2 blockers, which both work by telling your stomach to produce less acid in the first place.
Okay, so we've cracked all 3 case files. What's the final playbook? Let's boil all this down to the key takeaways you really need to hang on to.
So let's do a quick recap. Remember, H. pylori is an infection that leads to ulcers. Achalasia is a mechanical issue. That gate is stuck shut. And GERD is a barrier problem. The gate is too loose, letting acid escape. 3 very different problems, all with very different root causes.
And that brings us to our final thought. Understanding all this isn't just about memorizing facts. It's about learning to listen to your own body. Being able to recognize these signs and symptoms is always the first and honestly the most critical step toward taking control of your health. So what signals is your body sending you?
All right, let's dive in. Today, we're playing detective and investigating a pretty common medical mystery, peptic ulcers. Now, you might just think of it as a really bad stomach ache, but trust me, the story is so much deeper, and the clues, they're fascinating. So let's get our investigation started.
You've probably felt it, right? That nagging, burning pain deep in your stomach that makes you wonder, what is really going on in there? Is it just that spicy lunch?
Or is it a clue to something more serious? Well, that's the big question we're tackling today.
So first things first, in any investigation, we have to define the problem. A peptic ulcer is, pretty simply, an open sore. Just imagine the protective lining of your stomach getting worn down, and then that powerful stomach acid starts eating away at the tissue underneath. Ouch! That's where that burning pain comes from. Okay, now that we know what an ulcer is, the next question is who or what is to blame? Every good mystery has its culprits, and in this case, medical detectives have zeroed in on a few key suspects.
And you know what's interesting? The investigation has really narrowed the field. While a few things can play a part, it turns out that there are two main culprits responsible for the vast majority of these cases. Just two.
And here they are, our prime suspects. First up is a sneaky little bacterium called H. pylori. And get this, its discovery was a total game changer. For decades, everyone blamed stress and spicy food. But realizing this tiny organism was a primary cause actually won a Nobel Prize in 2005. It completely flipped how we treat ulcers. Our second culprit is the long-term use of NSAIDs, non-steroidal anti-inflammatory drugs. Think ibuprofen or aspirin. Over time, they can wear down that protective stomach lining.
Of course, our main suspects sometimes have accomplices. Things like smoking, drinking a bit too much alcohol, or dealing with really severe stress. They don't usually cause ulcers all by themselves. But what they do is weaken the stomach's defenses, basically rolling out the red carpet for our main culprits to come in and do their damage.
So, you've got the pain, and you know the potential culprits, but how do you figure out what's really going on? Well, the key to solving this mystery lies in one very specific, very important clue: the timing of your pain. Let's see how this all plays out. Now check this out. This is where the real detective work begins. We've got two main types of ulcers: gastric, which is in the stomach itself, and duodenal in the top part of the small intestine. With a gastric ulcer, eating actually makes the pain worse because food makes your stomach produce more acid right on top of that sore. But, and this is the cool part, with a duodenal ulcer, food acts like a temporary shield, so it makes the pain feel better for a bit, until your stomach empties out a few hours later and the pain comes roaring back. See how the location changes everything?
So the single most important thing to remember is this simple rule. It's like a secret decoder ring for medical investigators. If eating makes the pain better, you're almost certainly looking at a duodenal ulcer. If it makes the pain worse, all the clues point to a gastric ulcer. It's a surprisingly reliable trick.
Okay, so we've followed the clues, we've identified the type of ulcer, but the case isn't closed yet. The next phase is all about the resolution. How do we treat it and let the body heal?
And the treatment plan is actually a pretty logical three-step approach. Step 1, reduce that stomach acid. We do this with meds called PPIs or H2 blockers, which basically tell the acid pumps in your stomach to take a break. This gives the ulcer a chance to heal. Step 2, if our bacterial suspect, H. pylori, is on the scene, we get rid of it with antibiotics. And finally, Step 3, you got to avoid the accomplices. So stop the NSAIDs and cut back on the alcohol and smoking.
And here's where our story can take a much darker turn. Because cracking the case is one thing, but what happens if the clues are missed? What if that burning pain is just ignored for weeks or even months? The consequences can be really, really severe. Ignoring an ulcer is like letting a criminal run free. It doesn't just go away, it can escalate into something way more dangerous. So let's look at the serious complications that can happen when this whole thing goes untreated. The first major escalation is bleeding. An untreated ulcer can dig deep enough to hit a blood vessel, and that can cause a major gastrointestinal bleed. And yeah, that's as serious as it sounds. The warning signs of a bleeding ulcer are incredibly alarming and should never, ever be ignored. We're talking about vomiting blood, which can sometimes look like coffee grounds, or having black, tarry stools, which is what digested blood looks like. All that blood loss can make you feel weak, dizzy, cause a dangerous drop in blood pressure, and can even lead to a life-threatening condition called hypovolemic shock.
Now, as serious as bleeding is, there's an even more dangerous complication out there: perforation. This is the ulcer's absolute worst-case scenario. It's where it literally burns a hole all the way through the wall of your stomach or intestine.
A perforation is a full-blown medical emergency. The symptoms are unmistakable: a sudden, absolutely excruciating pain, and a stomach that feels rigid, almost like a board. Stomach contents spill out, causing a massive infection called peritonitis.
This requires immediate, life-saving surgery. There's no waiting this one out.
And that brings us right back to where we started. That burning pain might seem simple, but as we've just uncovered, it can be a critical clue in a much, much bigger mystery. The key takeaway here is that understanding these signs isn't just interesting trivia. It's about knowing when to get help. Because sometimes the most important mystery you'll ever solve is the one your own body is trying to tell you.
Okay, let's jump right in. We're going to talk about two conditions that you hear about all the time, often in the same sentence: Crohn's disease and ulcerative colitis. Now, they're both types of inflammatory bowel disease, IBD for short, but here's the thing, they are not the same. And knowing what sets them apart, well, that's absolutely crucial. So, that leads us to our big question. You've got these two diseases in the same IBD family. They both cause this chronic, long-term inflammation in your digestive tract. So, how in the world do you tell them apart? What are the key clues? That's the puzzle we are going to solve together today. And here's our game plan. First, we'll get a handle on what IBD even is. Then, we'll take a deep dive into Crohn's. And after that, we'll unpack ulcerative colitis. The best part? We'll put them head-to-head to see the key differences, and I'll leave you with a super simple way to remember it all. Let's get started. Okay, first things first. Let's zoom out and look at the big picture. What exactly is IBD? You know, in simple terms, IBD is the umbrella name for conditions where your gastrointestinal tract gets chronically inflamed. And chronic is the key word here. This isn't like a 24-hour stomach bug that comes and goes. Nope, this is a long-term persistent condition. And both Crohn's and ulcerative colitis live under this IBD umbrella. All right, let's tackle our first one, Crohn's disease. I like to call it the patchy attacker, and you're about to see exactly why that name fits so well. Okay, clue number one for understanding Crohn's is its incredible range. We're not talking about one specific spot. This thing can show up anywhere along the entire GI tract. I mean, literally from your mouth all the way down to the other end. And this is where that patchy nickname comes from. The inflammation doesn't happen in one big block. Instead, it shows up in these separated segments with perfectly healthy tissue in between. These are famously called skip lesions. But the other huge feature is its depth. The inflammation isn't just on the surface, it's transmural, which means it punches right through the entire thickness of the intestinal wall. That's a big deal. So you can imagine what this feels like for a patient, right? The symptoms are a direct result of that deep, patchy damage. You're going to see things like chronic diarrhea and really significant abdominal pain. And because that deep inflammation messes with your body's ability to absorb nutrients, weight loss and malnutrition are super common, along with just feeling exhausted and running a fever. Now, because that inflammation goes so deep, remember, it's transmural, the complications can get pretty serious. All that damage can cause blockages in the intestine. It can even lead to things called fistulas, which are basically these abnormal tunnels that form from the intestine to another organ, or sometimes even right through to the skin. And like a lot of chronic inflammatory diseases, it unfortunately raises the long-term risk of colon cancer. Okay, time to switch gears. Let's move on to our second condition and unpack ulcerative colitis, or UC. I call this one the continuous colon problem. And just like with Crohn's, that name tells you a whole lot. And boom, right away, here's the first huge difference. Remember how Crohn's could be anywhere? Well, ulcerative colitis is way more specific. It only ever affects the large intestine, that's the colon, and the rectum. That's it. Its territory is strictly limited. And its pattern is totally different too. Crohn's had those skip lesions, right? Well, UC has continuous inflammation. There are no skips. It usually starts down in the rectum and then spreads upwards through the colon in one big, uninterrupted swath of inflammation. And this is so important. The inflammation is superficial. It only affects the very inner lining of the intestinal wall, not the whole thing like Crohn's does. Now, some of the symptoms might sound similar to Crohn's, but there are some telltale differences. One of the hallmark signs of UC is often bloody diarrhea. And that makes sense, right? Because the inflammation is right there on that delicate inner lining, it can bleed really easily. Patients also often describe this really intense, urgent need to go to the bathroom, which can be incredibly distressing. The complications with UC are also very distinct and can be really, really serious. Maybe the most feared is something called toxic megacolon. That's where all that inflammation causes the colon to swell up and widen dramatically, which can actually lead to a life-threatening rupture. And just like with Crohn's, that long-term inflammation also leads to an increased risk of colon cancer down the line. Okay, we've looked at both of them on their own. Now it's time for the main event, the side-by-side showdown. This is where all those details are really going to click into place. So let's just nail down these crucial differences. Number 1, location. Crohn's is anywhere. UC is just the colon and rectum. Got it? Number 2, pattern. Crohn's is patchy with those skip lesions. UC is one continuous area. And finally, number 3, depth. Crohn's goes deep through the entire wall. UC stays superficial, only affecting the inner lining. Honestly, those 3 points are the whole code for telling them apart. Whew, that was a lot of info. So how are you supposed to make all of that stick? Well, let's get to a simple memory aid that's gonna help you out. And look, this isn't just some random trivia. The source material points out that these distinctions are constantly tested on medical and nursing exams, and for a very good reason. Getting this right is fundamental to making a proper diagnosis and getting a patient on the right treatment. It really, really matters. So, if you only remember one single thing from our whole chat today, please make it this sentence. It's the simplest, most powerful way to keep it all straight. Crohn's disease skips. Ulcerative colitis is continuous, and it's in the colon. That's it. That's the core of everything. So, we've cracked the clinical code. We know the what, the where, and the how. But I want to leave you with one last question to think about. Why does any of this matter so much? If we step away from the textbook for a second, how does getting an early, accurate diagnosis, getting it right, fundamentally change the entire course of a person's life and their journey with IBD?